This is the introduction to frequency specific microcurrent. The title says it's a new paradigm in medicine that changes your outcome. And the important part for me is that it changes lives, your life and your patients' lives. My name is Carol McMakin, and I have a master's in counseling. I'm a doctor of chiropractic in the state of Oregon, which makes me a GP that doesn't prescribe drugs. And I developed frequency specific microcurrent about 30 years ago. And this is my chance to tell you all about it. So, what is it? Frequency specific microcurrent is, I don't know if 30 years makes it new, but it's new to you or you wouldn't be here. It's a new tool you probably didn't know you needed that does some things that you didn't think were possible. I want you to think about FSM when you want to do something more than you've been able to do. I love people that have been in practice for about 10 years because you already know what you can and can't do. Something better than you could do it before. I'm afraid that it's something that makes you think and ask you why something happened, why the patient has this, and how it got there and how to fix it. Something that makes what you already do easier. FSM is not something you use by itself. It's something you use along with what you already do. It's something that makes what you already do work better. It makes it more effective. It's something that is otherwise impossible, and you'll find out more about that as we go along. Allows you to do something that is otherwise impossible. It's something that makes practice fun again. You know how frustrated you get when you just can't fix stuff? And the patient goes, I don't know. And you go, yeah, I'm really sorry. I know I was your last chance and I don't know what to do about it. So, how do we get here? It certainly didn't start 30 years ago. Frequency specific therapies were developed in the early 1900s, mostly by MDs and osteopaths in the US, the UK, and Germany. It's like how it all grew up all at the same time. And they were used by thousands of physicians, even in the US, up until about 1934. The Flexner Report was commissioned by the AMA and the Mayo brothers. It was published in 1910, and then people got busy with the epidemic in 1913, the other epidemic in 1916, 17, and then there was the pandemic in 1919. And that kept everybody busy. And then about 1920, 21, when the pandemic went away, then they started implementing the recommendations of the Flexner Report. The short version was that drugs and surgery were to be the only tools of medicine. Frequency therapies, nutrition, herbs, homeopathy were fakes and frauds and a quack. I love quack medicine, whatever that is. And eventually they were outlawed. Now, the Flexner Report always said there are too many medical schools, there are too many women doctors, too many Black doctors, and the Flexner Report recommended that medicine be an exclusive club populated mostly by white guys and that there be fewer of them. And as a result, by about 1927, every medical intervention except for prescription medication and surgery were outlawed. Physicians who used these tools would lose their licenses. The research and the history were lost when the researchers died. There were electromedical digests. There was a pathometric society. There's electromedical society. There were journals that we found in the rare book room. And those of you that have cleaned up when your grandparents died, your parents died, and you had to go through all these books that they started collecting when they were 25 and they died when they were 85, 60 years, right? That that was, what do you do with them? Do you remember? They all go on the trash heap. So all that history is lost, and I just have to live with that. The practitioners were persecuted. Some of them were put in jail. The devices went into the back room, got covered up with a sheet so nobody'd find them, or they just went in the trash. Now, this isn't one of the ones that was on the preceding page, but they look weird. History with FSM is that Harry Van Gelder was an osteopath and naturopath from Australia and the UK. This is Harry. He was about 82 when I met him, and he was Dutch. He bought a practice in 1946. You buy a practice and you walk around this building, and he walked in the back room, and there's this machine under a sheet, and it was made in 1922. So he took the sheet off, he looked at it, figured it out, and then underneath it, there was a list of frequencies. And I said, So he taught himself how to use it. And between osteopathy and homeopathy and nutrition and herbs, he became really famous in the western half of the United States and clear across Canada. Famous enough that George Douglas, that's this guy, my partner for 32 years, before I met George back in 1983, he had heard about Harry, and he went to chiropractic college so that he would have a license that allowed him to do what Harry did. And he went down to Ojai, California, and worked with Van Gelder for 3 months and learned what he needed to know. And he brought home a copy of the frequency list, and he put it in a drawer and forgot about it. This was what the frequency list looked like. There was one channel that was conditions to reverse certain pathologies as we think of stuff that's wrong with tissue. Too much histamine, scar tissue, 18 is bleeding, 40 is inflammation, 51 is fibrosis, 94 is nerve trauma, and then there's target tissues. So there's a page of different tissues. 10 is the spinal cord, 62 is blood vessels, 77 is connective tissue or flat tendons, 90 is the cortex, which is helpful when you're treating dementia. 142 is the fascia, and 396 is the nerve. Microcurrent devices were approved in the category of TENS devices by the FDA in 1971. Now, why are they TENS devices? They use 1,000 times less current than TENS. It's micro, millionths of an amp. But if you were a microcurrent device manufacturer and the FDA gave you the option of, you can be approved in the category of TENS devices for about $10,000, or we can make up a whole new category for you, and that'll be about $250,000. What would you do? So in 1971, they said, okay, we'll be TENS devices. At least then we have a 510K and we have FDA approval. So we already had a microcurrent device with 2 channels, and it had probes, and it had a meter that told you that it was conducting. And then I graduated, George and I got together in 1991, and then I graduated in 1994, opened a practice in 94, 95. And in 95, I started treating really difficult chronic fatigue and fibromyalgia patients. And George suggested, when I got frustrated with all these difficult patients, he suggested using the frequencies with a 2-channel microcurrent machine, because it's hard to tell from looking at this thing, but this is a radioclast. Harry's machine had 2 channels. Now, you have to understand that I have no idea how somebody in 1922 decided that 396 hertz was the frequency for the nerve and 40 hertz was the frequency for reducing inflammation. I have no idea how the frequencies were derived, and we've got a pretty good model for how they work, and you'll see that later, but I have no idea the exact mechanism because I can't find anybody that'll do the research. The 1920s equipment was not microcurrent. It was just DC current, direct current. Plug this machine in the wall and it produced DC current. microcurrent devices are battery operated. And the 1920s therapy was not FSM, we're unique. In 1995 and 96, we started out using the frequencies just to treat muscle pain. That started out in the neck, actually. And then throughout 95 and actually through most of 96, we did blinded treatments and active treatments. I wasn't operating the machine, Christy Hughes was. And she'd leave the machine off sometimes. She'd put the frequencies in. And we used blinded and active treatments in 95 and 96 to ensure that they were safe, right? First, do no harm. And did they work? Could I tell if the frequencies were effective? In 98, we found out we could treat nerve pain. 96, 97, we treated muscle pain. Nerve pain was 98. Peripheral neuropathies was 98. Started treating fibromyalgia from spine trauma in 99. The first organized study on dissolving or reducing scar tissue was done in 2003, thanks to Bart Flick and Mercy St. John's burn unit in Springfield, Missouri. And then January of 97, I had to teach it to find out if it was real. The only way to find out if something is real is to make it reproducible. Well, you can't do blinded trials when you're in private practice. So I had to teach it. Is it a placebo? Is it real? So I taught it in January, and by June, we had 10 people that bought machines from Doug Casey. And by June, we found out that the results were reproducible. So then we knew it was teachable, and I didn't teach it very well, and it was reproducible. So the benefits and effects since then, as you're going to see in the next hour, were teachable and reproducible, and animal and human research and the clinical results have accumulated since then. It took me 5 years and 50,000 patient visits to decide that the frequencies always did what they were described as doing. Now, the devices are proved in the category of tens in 1971. The current is in millionths of an amp. You can't feel it, so it's great for blinded trials. It's not tens, it's 1,000 times less current, but we can only talk about the devices as if they are tens devices. Their microcurrent devices are category 1 by estheticians for treating facials, doing facials. That's non-prescription. There are lots of studies, like over 200 studies on using microamperage current, just the current, 0.3 of a hertz, no frequencies, just single channel DC current for wound healing and pain control. The devices you need for FSM need 2 channels that are independent. So you can use channel A to 3 frequencies and a decimal point, channel B, 3 numbers, hundreds, tens, and ones, and a decimal point. They have to be a constant current generator so that when you set the current for, let's say, 100 microamps, the machine, the device, will vary the voltage to whatever you need, up to about 20 volts, to keep the current constant. You need a screen that tells you what frequencies are running so that if you have a good result or a not good result, you know what caused it. You can look at the screen and find out what frequency. So that you need to know the frequency, the current, the polarity. Precision Distributing is the company we use that distributes our devices. They're made in the US. There are Chinese devices made, and I'm not even going to go there. Ours are 510Ks are easy, but ours are also, or PDIs are also ISO certified. Come on. Microcurrent by itself, just the current. There are 3 studies. First one was done in 1982 by Nak Cheng, then reproduced by Seegers from South Africa in 2001 and 2002. If used between 10 and 500 microamps, it increases ATP production by 500%. That increases protein synthesis by 70%. That increases amino acid transport by 70%. And then in Seeger's work, she found out that you increase cyclic AMP in human lymphocytes. That's interesting, in vivo. And she also discovered that it increases signal transduction. That means the communication between one cell and the other, because she was looking at how the lymphocytes communicated with each other. If you go between 500 and 1,000 microamps, ATP stopped increasing. Above 1,000 microamps, it reduces ATP. So it pays to keep the current below. We usually use up to 200 microamps. There was a PhD thesis done at University of Washington. It's unpublished because it's a PhD thesis. You don't publish it. And it was done for the aesthetics industry, facials. They don't care about peer-reviewed literature. But what they found out was if you ran microcurrent an hour a day, 5 days a week on a rabbit, so you do a biopsy of the bunny, and then you wait for the biopsy to heal, and then you run microcurrent for 20 days, an hour a day for 20 days. That's 4 weeks, 5 days a week. You get wound healing and repair tissue where the blood supply increases by 39%. So here's that biopsy, but what does that mean in the real world? That means the repair tissue from the original wound the bunny had is healthy. It's got a good blood supply that increased by 39%. Then see these little black lines? This is collagen increases by 14%. Well, that means that the repair tissue is strong, not just healthy, but strong. And the most important is that it increases elastin by 48%. Elastin's hard to increase. That means that the repair tissue you get on this wound is flexible. Now, I got to write, thanks to Leon Chateau, I got to write a textbook. Elsevier is the world's largest textbook publisher. So the FSM textbook was written in 2010. It's recommended. My favorite book is The Resonance Effect. It's now in English, French, German, Mandarin, Polish, about to be in Japanese and Spanish. It's a book for patients. It's the story of how FSM really started, and I highly recommend it. It's a great story. Jim Oshman loved it. He called it a page turner. Can't put it down. It's on Amazon. It's an Audible effect. It's at theresonanceeffect.org. It's at frequencyspecific.com. Okay, if a 500% increase in ATP is the effect of the current, what happens when you add the effects of the frequencies? How come those work? Just plain microcurrent, single channel, 0.3 of a hertz, that does good things to bunnies. What happens when you add the effects of the frequency? What we found out was that the clinical response is frequency specific. The frequency effect matches the description on the list. Remember the list I got in 1994? Inflammation, 40 hertz clinically, reduces pain, redness, and swelling. Didn't do anything for range of motion. Nothing. It would just take a rheumatoid arthritis knee from a grapefruit to an orange. Fibrosis and scarring. Dissolves scar tissue, softens scar tissue, increases range of motion, doesn't reduce pain unless the scarring is causing the pain, doesn't reduce inflammation at all, frequency to stop bleeding, prevents bruising and new injuries, stops bleeding, reduces pain in the menses, reduces flow in the menses, has no effect on inflammation. There's one frequency combination. It's AB pairs that you see here, all of these 3 pairs, because the virus has mutated in about 10 years, where it was just this pair. Then it mutated for about 5 years. And then after 15 years, we had to have this 3rd pair. That was George. It reduces pain, eliminates lesions, doesn't do anything else. It's not good for anything except shingles, period. The clinical use of frequency specific is low risk. How come I could teach it when we didn't have studies? What we found out in that year was that frequencies either work or they don't work. If they don't work, they just have no effect. You'll have side effects every now and then, but those are transient as long as you observe the precautions and contraindications, like you can't take apart scar tissue until the scar tissue is 6 weeks after the injury. And fortunately for me, medicine's pragmatic. The first question is, does it work? They used willow bark for what, 500 years? And then they found out that willow bark was salicylic, the active ingredient in willow bark was salicylic acid, and they made that into aspirin in the hundreds, 1920s. And that was used for hundreds of years. And they had no idea why it worked. Not the faintest clue until the 1970s, 1968, 69, 70, 71. I became a pharmaceutical rep. And Upjohn released ibuprofen in 1970. And in the process of their manufacture and research about ibuprofen, they found out about prostaglandins, prostaglandin E1, E2, right? Medicine's pragmatic. Efficacy first. The first question about FSM is, about any frequency, is, does it work? Okay. We have aspirin, we have ibuprofen, we have this frequency 40 and 116. We had this mouse research in Australia. It's a blinded mouse trial. There's Wayne Wiley holding this mouse and running this frequency 40 and 116. So they paint arachidonic acid on the mouse's ears. It causes the mouse's ears to swell. Lady measures the mouse's ear with a caliper, and then they ran 40 and 116, and they got a 70% reduction in lipoxygenase-mediated inflammation, which caused Vivian Reed, the PhD that was running this trial, to shut down the lab, send everybody home, and bring everybody back blinded. They put paper over the doors, put everybody in separate rooms, because in 20 years of doing this research, she'd never seen prescription or non-prescription medication that reduced lipoxygenase-mediated inflammation by more than 45%. So she figured people were cheating. As a blind trial, she brought him back to the lab, and there's 40 and 116, and she turned the machine away from Dr. Riley, and he's running a placebo frequency, 40 and 00. And with everybody being real careful, they got a 62% reduction in lipoxygenase-mediated inflammation. And the thing was, that was the first time we found out, number one, all the animals responded, but it was a 4-minute time-dependent response. So 50% of the effect was present in 2 minutes. The full effect was present at 4 minutes. What would happen if you could reduce lipoxygenase-mediated inflammation by 62% in 4 minutes? Google sometime what conditions in humans are lipoxygenase-mediated inflammation: irritable bowel, inflammatory bowel, Crohn's, leaky gut, liver disease, pancreatitis, rheumatoid arthritis, any kind of arthritis, asthma, cardiovascular disease, diabetes, neurodegenerative diseases, including depression and anxiety, and nerve pain, are all LOX-mediated. And then only one frequency reduced inflammation. In this blinded animal research, they had a 30% reduction in COX-mediated inflammation. Doesn't sound quite as spectacular, but that's equivalent to injectable Toradol, which is what they use after you've had your hip replaced. All the animals responded in a 4-minute time-dependent response, so 50% was present at 2 minutes. Full effect was present at 4 minutes, and there it is. It's a 30% reduction. With 40 is reduce inflammation. 116 is the frequency for the immune system as compared to a placebo. Okay, what does that mean? What would happen if you could reduce COX-mediated inflammation by 30% in 4 minutes? In arthritis, menstrual pain, you take ibuprofen. That's a COX-2 inhibitor. Any autoimmune disease like rheumatoid arthritis, any neurodegenerative disease, Alzheimer's, Creutzfeldt-Jakob disease, various kinds of dementias, COPD, lung conditions, cardiovascular disease, traumatic brain injuries, minimal traumatic brain injuries, depressions, anxiety, back pain, neck pain, joint pain. That's all COX-mediated. Now, if you take ibuprofen long enough, it lasts 4 to 6 to 12 hours, and it messes with your gut and it messes with your kidneys, because those prostaglandins in cyclooxygenase help rebuild the arteries in your heart and your kidneys. FSM doesn't last that long. It changes the way the cells work, and I'll explain that later. But it means that you're not just suppressing the cyclooxygenase inflammation. So you're not going to damage the arteries in the heart. There's no evidence we're going to damage anybody's kidneys. And the other thing I asked them to check was, will any other frequency work? So they checked 1/10 of a hertz to find out if just the current would reduce swelling in the ear, no reduction in swelling. So there's your other frequencies. 4 minutes of R frequencies for mineral deposits in bone, no reduction in swelling. 4 minutes of what we will call the intermediate injury frequencies, which didn't include 40, no reduction in swelling. And both channels had to be correct. If you do reduce inflammation 40 and 355 the skin, there was no reduction in air swelling. Then we found out in 1999 that we could treat fibromyalgia associated with spine trauma. So I presented 27 cases at NIH. By the time we got this paper published in 2005, there were 54 fibromyalgia patients with a history of spine trauma. Average chronicity was almost 10 years, 5.5, 9.5 years as an average. And after I gave Grand Rounds presentation at NIH, thanks to our third author, Terry Phillips, we got blood sample data on 6 patients. The control patient had myofascial trigger points. This is what the pain diagram looks like. Those of you that are clinicians, this is your scariest patient. This lady is 75 years old. She's been in pain for 50 years. Her pain is an average of about a 6 out of 10. I've seen about 400 of these pain patterns. So the pain pattern looks very much the same. They have chronic non-restorative sleep. They have hyperactive patellar reflexes. They have hypersensitive dermatomes, specific nerve roots that are hypersensitive. And as a group, they're the only fibromyalgia patients who specifically complain about pain in their hands and feet. So we found out in 1999 that only one frequency reduced the pain, and that was 40 and 10, reduce inflammation in the spinal cord. And you had to hook the patient up from neck to feet, whether they could sit in a chair, and these two have leotards on. We would put them in a gown, cover them up in a blanket. The pain was reduced from an average of a 7.4 to a 1.3 out of 10 in 90 minutes. And then all of the cytokines were reduced in 90 minutes. And then to recover from fibromyalgia, they had FSM, they had to keep their pain below a 4. Almost everybody had physical therapy to help repair the disc in their neck, disc injury in their neck that caused the problem. And they had reconditioning. We treat the gut, we treat their adrenals and their endocrine system, since fibromyalgia is a neuroendocrine condition. Medication management and withdrawal is what takes the longest. 58%, almost 60% of these patients were recovered in 4 months. Now, it took us 5 years to get this paper published, because the first 4 times, the title of the paper was Resolution of Fibromyalgia Associated with Spine Trauma. And no journal, at least no journal, wanted to hear that fibromyalgia could be resolved, much less 68% of them could be resolved. So we had to change the title and make the title cytokine changes. We could get it published if we made it about the cytokine changes. There were 13 of the 54 patients who discontinued treatment. After about 4 to 6 sessions, these patients recovered in 4 months. These 13 patients discontinued treatment in about 2 to 6 weeks for reasons not related to treatment side effects. If your pain has been an average of a 7 for, 9 years, and somebody takes you from a 7 to a 1 in 90 minutes, FSM has the ability to create an identity crisis that is unparalleled in medicine. You just can't get there any other way. So I think that's why those patients discontinued treatment. We're much better at this now because we can we figured out how to treat central sensitization and help the patient accommodate to the change in their pain level more quickly. So this is what we found out in the blood sample data from the National Institutes of Health, thanks to Terry Phillips. This is the index patient, the first patient I tested. She came in, her interleukin-1 was 392, that's her. And 12 noon, her pain was a 0. And by 12:35, so between 12 noon and 12:35, I ran what Harry Van Gelder called the concussion protocol. And I wanted to see what would change. And so the cytokines went from 392 down to 21. Those of you that know about cytokines know that cytokines with medical intervention change very slowly. They're hard to change. And once they change slowly over months, there is no medical intervention that changes cytokines by a factor of 20 times in 90 minutes. Just doesn't happen. And I only got data on these 5 patients, and I only had 3 visits. So this isn't the world's best data collection, but look at the numbers. Interleukin-1, TNF alpha, hard to change, 299 down to 20. So that's what is 30 times? The p-value, for those of you that do statistics, is 0.002, which means there is 0 chance that it changed by chance. Substance P is a peptide produced in the spinal cord. And what this means, it went from 132 down to 10. So it changed by 10 times in 90 minutes. P-value has 3 zeros and a 1 with a sample of 1, 2, 3, 4, 5, 6, 7, right? Those of you that know statistics know that that's not possible. P-value with 3 zeros and a 1 in a sample size of 7, that is just statistically huge. And substance P is made in the spinal cord. So what that means is 10 really does mean that we're affecting the spinal cord. Beta endorphins go up. Look at this, right? Look how steep they are. So I started at 10:50 in the morning. Pain level was a 7. And by 11:20, so that is in 30 minutes, her endorphins had doubled. So she was at a 10. By 11:35, so 15 minutes later, she looked up at me and said, "Is this illegal?" So they get really floaty, and we just call it dwarfed for endorphins. You can also call it stoned. I tell people it's completely legal in all 50 states. We don't charge extra for it. It's just part of the service. And endorphins went from 5 to 88. It increased by more than 10 times. And endorphins are what create the runner's high. And then pain relief leads to recovery. When your pain level goes up to a 7, your endocrine system changes. Every patient had pain relief. And if the pain stayed below a 4, 58% of the patients recovered in 4 months, right? So this p-value with 57 patients actually has 6 zeros and a 1. And the statistician says, yeah, anything more than 3 zeros and a 1 is just showing off, so we don't publish those. So what would happen to your outcomes? Think about what you do in your practice every single day. What would happen if you could reduce lipoxygenase inflammation by 62%, COX inflammation by 30%, all of the inflammatory cytokines? So I left out CGRP and a bunch of other ones that we tested, and increase ATP production by 500% in, let's say, 30 to 60 minutes. What would happen to your outcomes? What would happen to your patients? What would happen to your practice? For example, in medicine, resolving scar tissue is expensive, painful, difficult, or impossible. Yeah, you can use lasers, you can use metal gadgets, you can inject stuff into it. It's time consuming, painful, difficult, or impossible. And with FSM, it's just easy. 2003 at the burn unit in Springfield, Missouri. This is the surgical team there. Actually, it's a nursing team there. We did an 8-patient pilot trial. They were tested by the PTs on Monday and Friday of the first week. I treated patients on Tuesday, Wednesday, Thursday for an hour. Every patient had statistically significant permanent increases in range of motion after 3 one-hour treatments. So they were tested range of motion Monday, Friday, and every Friday for a month, and then once every 2 weeks for 3 months. And the changes in range of motion were permanent. This was published as an abstract at the Pacific Rim Burn Conference in 2003. In Taiwan, this is just a case report. Patient had a 3-year chronic full thickness burn. Before treatment, his range of motion in his elbow, his clothing was burned in a fireworks accident. His elbow was stuck in 15 degrees of flexion and could not straighten because of all of the connective tissue, scar tissue. And after 1 hour of FSM, he was at 0 degrees of flexion with full and pain-free range of motion in the elbow. So you treat scarring in the connective tissue, the blood supply, the nerves, the joint capsule, and just all the tissues in the elbow. This is just pictures. This is just a case report from, I think, 2013. Man had a serious laceration in his hand. A fairly decent hand surgeon put it back together, but this was his scarring, I think about 6 months after the injury and the surgery. And this was 5 treatments with FSM, remove scarring from the blood supply, the connective tissue, the nerves, and the skin. So you have to do all the layers. But look at the difference in 5 treatments, right? And this is a published paper. FSM resolves chronic pain and adhesions after ulnar transposition surgery. Patient was 19. He had the surgery to transpose the ulnar nerve from the groove out into the elbow. No change in pain or range of motion, unfortunately. So 9 years later, he had an increase in pain, reduced range of motion. His functional score was 86% out of 100. Had 11 physical therapy sessions with ASTIM, electrical stim, ice, exercise. His pain at discharge went from a 5 to a 4. His Taos was 92%. 1 year later, his pain was a 7, so it was worse. The range of motion was worse, and his Taos score was worse at 80%. So we did 3 sessions of FSM with the contacts at his neck and his forearm and manipulated the scar tissue in the arm. So the frequencies vibrate the links that hold the scar tissue together, but once they're vibrating, you have to move them with your fingers. Eliminated the pain, improved the range of motion because we could treat the nerve with reduced inflammation in the nerve that would make the pain a 0. Dissolved the scar tissue. The Taos was 100%, and the results were maintained at 1 year follow-up. Taos was 100%, pain was still a 0. There are 100 million people in the United States have nerve pain at some time in their lives. In medicine, nerve pain is difficult or impossible to treat. With FSM, honest to goodness, nerve pain is the easiest thing we treat. You do reduce inflammation in the nerve, look in the literature. That's what causes nerve pain. Treat inflammation in the nerve and it goes away. We have 1 published paper in a small group, N of 20. This was out of my practice. Average chronicity was 7 years. Every patient that was treated experienced pain reduction. First treatment, the pain went from an average of a 7 to an average of about a 2. That p-value with 20 patients had 2 zeros and a 1. It went up from a 2 to almost a 5, 4.8 out of 10. And at the end of that hour, the pain was a 1 out of 10. That p-value had 2 zeros and a 1. 65%, 13 out of the 20, fully recovered in about 5 treatments, and it ranged from 1 to 15, because where the nerve pain is being caused by a disc, you have to get the disc to be repaired. No adverse reaction aside from being a little bit stoned. 25% terminated care prior to recovery, even though every patient had pain reduction. Why'd they stop getting treated? Why'd they stop? They stopped because if you've been in pain for an average of 7 years and at the end of an hour you're pain free, you don't know who you are. You create an identity crisis that is virtually unparalleled in medicine. This is non-pharmacologic treatment of neuropathic pain with frequency specific microcurrent in the pain practitioner, fall of 2010. Neck pain, 50 cases published in 1998, 5 years average chronicity. 88% of the range was 1 year to 28 years. 88% had failed with 3 to 6 other practitioner types. We were always the court of last resort. I figured the patients were their own controls. If they were going to have a placebo effect, they would have had it with one of the 3 to 6 other kinds of practitioners that treated them before me. There was an average of 11 visits in 8 weeks to get their pain from an average of a 7 to an average of a 1.5. This was published in Topics in Clinical Chiropractic, 1998, and it took that many treatments because I didn't know what I was doing. Low back pain, this was easier. 8 years chronicity, so they were more chronic. Range was 1 to 20 years, a couple of months to 20 years. 87% had failed with 3 to 6 other practitioner types. Patients, once again, were their own controls. If it was a placebo effect, it would have happened with one of the 6 other people who treated them before they got to me. It was an average. This is normal for neck and low back pain. 6 treatments in 6 weeks get their pain from an average of about a 7 to an average of about a 1.5. This is a much larger trial done in India. Low back pain, 213 in the FSM group, 167 in the control group. NP this is LBP, low back pain. Neck pain patients, there was no significant difference. Talking to the authors, I found out it was because they were using the wrong protocols. But the p-value, there was FSM results considering all objective measures in 213 patients. The p-value has 2 zeros and a 6. Shingles, this is a case report. Pain-free. This patient was 85 years old, ophthalmic branch of 5. He was pain-free in 1 hour. No return of pain. He had a total of 4 hours of treatment in 2 days. The lesions were dried up and pretty much gone in 48 hours. The pain went away and never came back. Shingles in the ophthalmic branch of 5 in an 85-year-old man almost universally results in postherpetic neuralgia. This patient had no return of pain, and we've had no failures in 26 years if treated in the prodrome. If you wait for 2 weeks, then what you're treating is postherpetic neuralgia, and that's a whole nother problem. FSM improves healing. Think about it. Reduce inflammation, stop bleeding. Neurologic recovery. This is a 38-year-old stroke patient, 3 years chronic, with normal flexion spasticity at the shoulder, elbow, traps, hand. We treated from her neck to her feet. At the end of about an hour, her arm was relaxed. We ran the frequencies to increase secretions in the sensory cortex. Hand was relaxed. This is a physical therapist who's doing very slow PT stroke range of motion. At the end of an hour, got the patient to range of motion above her head. We took the machine off of her at the end of about an hour, and her arm stayed above her head. We did not work on her leg, and I didn't believe it was going to work. So 5 days later, 6 days later, we treated her for another hour, and this is her result at the end of the second hour of treatment. I came back the next year to Taiwan and found out she had a subsequent stroke. So we didn't find out if we could have been able to fix her leg spasticity. But the frequency combination to increase secretions in the frequency we have for the sensory motor cortex, reduces stroke spasticity consistently, also works in cerebral palsy. Healing, delayed onset muscle soreness. This is a controlled trial published in JBMT in 2010. This is 22 patients. And the problem with this is an active machine, this is passive leg. It's concentric exercises that are designed to create pain after exercise. Baseline had to be 0. Patients were on no pain medication. 24 hours of treated leg, the pain was a 1.3, the sham leg. So one machine was turned on, one machine was turned off, and the frequencies were published with the paper. Sham leg was a 5. Day 2, they knew which one was the sham leg because the pain was a 1 and the sham leg was a 7. 72 hours, pain leg was less than a 1 and sham leg was 4. So the p-value with 22 patients is 3 zeros and a 5. Those of you that know statistics know that's not possible with 22 patients. And this compared non-specific microcurrent, published paper by Adams in 1999, showing that non-frequency specific microcurrent didn't work. It increases healing. This is post facelift. This lady had a brow lift, mid face, lower face, chin. They didn't do her eyes. Good surgical technique, drains, compression, ice packs. She had a teddy bear. Day 2, you can see the bandages where they did the brow lift laparoscopically. There's a mid face, a little bit of swelling, no bruising. Day 2, that's not possible. Day 4, this is 80 minutes treatment immediately post-op and daily for 7 days. Day 4, little bit of bruising under the eyes where the brow has leaked down under the eyes. Day 5, bruising's pretty much gone. So they treated her every day for 90 minutes for 7 days. So day 5, there's no bruising. There's day 6. She still got the Band-Aid on, but with her hair down, doesn't look swollen at all. This is Marissa Brennan. She's a massage therapist in Florida, presented this case in 2013. With the lady's hair back, you can see the swelling in her cheeks. And day 11, with makeup on, I'll give you that, but there's no bruising. And those of you that know about facelifts knows that nobody looks like this 11 days after a full facelift. It just didn't happen. They're bruised black and blue down below their clavicles for close to 4 weeks. Diabetic wounds and diabetic neuropathies, 7-centimeter ulcer on the medial aspect of the left leg. That was healed in 6 treatments over 3 weeks. This was a case report presented by Nora Collier in 2003. 6 treatments in 3 weeks. And then this is the one I love the best. He had necrosis beginning on the 3rd toe that I think it had a total of 12 treatments in 6 weeks. So between July 10th and July 30th, so basically 20 days, they were treating him twice a week for 4 weeks. Pretty sure the total was twice a week for 6 weeks. But they were waiting for this necrosis to get worse so they could amputate both of these toes at the same time. The necrosis went away. Sensation was lost in 8 out of 10 sensory areas in the bottom of the foot and completely normal 1 month later, twice a week for 4 weeks. That's the sensation. The thing you need to know is the US spends $11 billion, $13 billion on diabetic wound care every year and $11 billion on amputations after the wound care fails. And for FSM, it's unattended. You can towel around the wet towel. This is conductive material that water conducts. At the knees and at the feet, you can use adhesive electrodes if the patient tolerates adhesives. And I don't know that the money is why I have not been able to get any wound care facility to participate in a control trial on using FSM in diabetic wounds and neuropathies. Pretty frustrating. And it might have something to do with the money. I really don't know. It might just be that they're used to doing it the way they're used to doing it, and they don't want to add microcurrent to it. This is an acute burn, second-degree burn. You can see the blistering. He spilled hot oil on himself, and this is 4 treatments in 11 days. And he went from this with blistering to pretty close to normal skin in 11 days. So how does this happen with just frequencies and microcurrent? Think about it. What you've just seen is the impossible, and we do it all the time. I'm a scientist. That master's degree got me started. And so science is a method of observation. How does science explain the observed effects, what you just saw with FSM? It has to do with biophysics. Newtonian physics describes the activity of large objects, but it fails to describe quantum molecular behavior. When people throw that word quantum around, what does it mean? And how does it apply to the human body? Your body is a large object made of quantum particles. Molecules are collections of atoms, and molecules are held together by subatomic quantum particles. And all of this is held together by electromagnetic bonds. So there's liver tissue, but a liver is a collection of molecules, atoms, and subatomic particles. This is insulin. It's not really insulin. It is molecules, atoms, and subatomic particles. Interleukin 1 that you saw measured by NIH looks like this. Substance P looks like this. See all these little bonds? Every bond, every electromagnetic bond that holds all these atoms and molecules together has a frequency at which it resonates. I'll explain what that means in a second. First, we have to go to how does a body conduct current? How do you put current in at the neck or the knees and the feet and have it do anything? There's water that lines the gel inside cells and forms structure that acts as a semiconductor. Now, it's a different way of looking at cells. We think of cells as like little bags filled with water. They're not. They're filled with a gel matrix, and the water is organized. It's attached to this gel lattice. And the water molecules vibrate. They're held in place, so they're always in the same place. And they vibrate so that the hydrogen atoms flicker back and forth. And if you know how a hydrogen atom and a water molecule is put together, there's a hole in the outer edge in a hydrogen atom. And that leaves a hole in the same place all the time. Now, a conductor is like copper. There's 2 holes. Copper is +2. That means it's missing 2 electrons. So electrons can just go zipping along. It is a conductor, and the electrons flow really fast. Insulators, like ceramic, there's no electrons because everything's full. It's ceramic. There's no empty spots. It's an insulator. This is silicon. Silicon forms a matrix that has a hole in exactly the same place. That's why those guys wear those paper suits with the hats and the boots and the gloves and the masks and everything. because it has to be pure. That hole can't be disrupted or it messes up the silicon chip that's in your computer. Water lines this gel matrix, hydrogen molecules vibrate and turn the cell into a semiconductor with a hole in the same place all the time, making your body, the water in your body, is like a semiconductor computer chip, allowing controlled electron flow. So your body is an electromagnetic system that looks solid, but cells function as a semiconductor network that conveys current, charge, and information. And this is all in books that you can read. Albert St. Georgi was a biophysicist. Molecules do not have to touch each other to interact. Water forms structures that transmit energy. This guy started research in the 40s, and he published this paper in 1988. Becker published The Body Electric, showing that people are polarized positive at the top, negative at the bottom, positive centrally, negative distally. It's an electromagnetic conducting system. The perineurium, the lining of the nerve, is a direct current system that conveys information throughout the body and creates healing. You really ought to read The Body Electric. Jim Oshman is a biophysicist who works across the hall from St. Georgi, and he wrote Energy Medicine, the Scientific Basis. The first edition was brilliant. The second edition is even better. And Jerry Pollack wrote, at water-friendly surfaces, water molecules often shed their hydrogen ions and organize into orderly lattices. And he published Cells, Gels, and the Engines of Life. It is an extraordinary look at cell biology. And then there is The Fourth Phase of Water, his next and most famous book. So what's resonance? It's the tendency of a system or a bond to oscillate at large amplitudes in response to some frequencies and not others. At the resonant frequency, very small forces can produce very large amplitude vibrations. So they found out in the 1800s, late 1700s, but 1800s for sure, that soldiers marching across a bridge, marching in step across a bridge, can create a vibration that reaches resonance with the frequency that holds the bridge together. And every soldier to this day, companies of soldier break step when they get to a bridge and go back into step when they get across it. And that's because enough bridges fell down because of armies walking across them that they found out that's resonance. Resonance explains how a singer breaks a lead crystal glass. My chemistry teacher told me about this. There is a frequency, precise frequency that holds lead atoms together in a 70% lead crystal matrix. The lead atom bonds vibrate with the singer's note as long as it is precise at that frequency and sustained. The lead atoms vibrate and it just comes apart because of resonance, not volume. It causes the lead atoms to oscillate, destabilizing the bonds that create the crystal, and the crystal glass comes apart. It just shatters. Resonance is science. There's nothing woo-woo about this at all. If you have two tuning forks tuned to the same frequency, 128 hertz, and you set them 5 feet apart and you hit this one, the one across the room will stop vibrating. And if you put a little ball next to it, this is in a physics class, the ball is going to bounce. If you put a board or a piece of paper or something to block the vibration, something interferes with resonance, it blocks the resonance and interferes with the frequency transfer. You remove the interference and resonance and proper frequency returns. Biologic resonance is the same thing. It's biophysics. It explains the effects on living tissue. Now, this is a cell. Drug and nutrients acts like keys in a lock. Let's say you have a paper cut. This is damage-associated molecular patterns. The cell is covered with hundreds or thousands of these little receptors, and you have damage-associated molecular patterns from the little paper cut, and you have pathogens, staph, the coccus, which is on your skin, hit this receptor that activates kinases, that activates transcription factors, NF-kappa B, and a bunch of other ones. That changes genetic expression. That changes the DNA, stimulates messenger RNA, which stimulates microRNA, and the microRNA puts together inflammatory cytokines. And the biological answer to your paper cut, this is why your paper cut gets red, swollen, and painful. It's because of this cellular response. So now your finger is throbbing. You take an ibuprofen. Now the ibuprofen lands on this receptor, and that blocks it and stops it from interacting with the PAMPs and the DAMPs, and that changes the kinases and the transcription factors, and then it turns off the inflammatory cytokines and the LOX and the COX for about 4 to 6 to 8 hours. Okay. Biologic resonance frequencies act like your key fob, opening a lock with an electromagnetic signal. The frequencies appear to change membrane protein configuration and cell function electromagnetically with a frequency-specific signal. If you used a key fob to open your car today, you used frequency-specific resonance. We use 40 hertz, and it reduces interleukin-1. How does it do that? It reduced all of the inflammatory cytokines, so it didn't interfere with just interleukin-1. It has to be logical, right? It has to affect this receptor the same way that your ibuprofen does, interferes with kinases, transcription factors, genetic expression, and the biological answer, the messenger and microRNA that create pro-inflammatory cytokines. Frequencies appear to resonate with cell receptors, and they act as if they change cell signaling to reduce inflammation. They act as if they modify scar tissue crosslinks to reduce the scarring. It's the only thing that makes sense. It's the only thing that matches our data. Membrane receptors appear to respond to frequency signaling. Membrane protein receptors determine cell function. The receptors reconfigure in response to stimuli, information, and frequencies that activate kinases, that alter genetic expression, cell function, and structure. FSM treatment we've been around since 1997, so that's what, close on to 30 years. It's low risk, doesn't hurt anybody. Reproducible, it's definitely teachable. I teach it a lot better now than I did 20, 30 years ago. It's evidence-based. We have evidence, not as much as I want, but we have evidence. It's reliable. You do the same thing for nerve pain every time you do it, and it's going to work every time. It's non-invasive, doesn't hurt, it's comfortable, it's billable because the devices are approved as if they're TENS devices. So even if you're treating irritable bowel or asthma or COPD or all of the things that you saw in the LOX and COX list, you have to have a pain diagnosis because the devices are approved as if they're TENS devices. We have reliable US made equipment that's inexpensive compared to almost everything else you buy for an office. It can make any therapy. I don't care if you're an MD, a DO, a PT, an OT, a massage therapist, a naturopath, an acupuncturist. We have practitioners in virtually every clinical profession. Make anything you do more effective, more efficient, less expensive, improve your outcomes. And the point of the fact is, it changes lives, changes your life, changes your patient life. So I want you to think about FSM when you want to do something more than you did before, something better than you did before, something that makes you think and ask about, why is this tissue the way it is? Why is it painful? Why didn't it work? Why is the range of motion what it is? How did that happen and how can I fix it? Something that makes what you already do easier than it was yesterday. Something that makes what you do already do more effective than it was. And something that is otherwise impossible. It is impossible for a patient with a complete facelift to look like that 11 days after the surgery. And it's something that makes practice fun again, because you can do the coolest stuff. And I teach a 5-day seminar. Now, it's like taking a drink of water out of a fire hose. 50% of the seminar is differential diagnosis, because you have to treat the right thing with the right thing. We do demonstrations, and then you do practicums. You do twice a day for 5 days. There's a core seminar. You can take it in person. I recommend taking it on video before you take it in person, because it's a lot. 5 days of lecture from 9 in the morning until 6 o'clock at night. Most of the time, by about day 3, I have to kick people out of the room at 7:30. There's an 8-hour hands-on practicum. If you watch it on video, you get 4 hours private time with one of our instructors. You get individual attention, because I have one instructor for every 2 tables, and there's 3 people per table. By the time you leave Sunday, you're competent. You're not good at it yet. There's a pretty steep learning curve the first 3 months. And then there's this 3-month up until forever. I'm still learning things after doing this for 30 years. There are advanced courses, webinars, workshops. We keep you learning. We do a podcast every week where we talk about things we learned last week. Inexpensive equipment, it's billable. Equipment has a 510K, a CE mark, it's ISO certified, and it's US made, and I'm proud of Precision Distributing. I have to warn you though, it will change your life. Use it on yourself. It changes your health. I'm 78 years old and I'm still working a good 8-9 hours a day. Changes your life, your health, your practice, and your outcomes forever. I challenge you or invite you to join us, Frequency Specific Microcurrent. Take a course. You change one life, you change the world. And if you're not here to change the world, you got to ask, what are you here for? It's more fun than you will ever have in medicine. Thanks for listening. Hope you enjoyed it. And I'll hope to see you at a seminar.
Questions.
I have questions.
Just click on that
Not the chat.
Q&A. Yeah, so
This-
one.
That one. Okay.
And then
Q&A. 16 questions. Thank you, Susan. Resonance affected suburbs. She read the book. Dupont-Tarrant contracture. Yeah, it depends on how bad it is, how long they've had it, and how long they've had it. I can't say I've been 100% effective. I've made it more comfortable. If you can get the connective tissue disconnected from the nerves, it doesn't hurt as much. If it's been around long enough that the joint capsule is fused and the cartilage in the joint is fused, send them to a good hand surgeon, treat them immediately after the surgery, and assuming the hand surgeon doesn't cut anything important, they're pretty good in about 2-3 weeks. Yes. Tinnitus, Patrick, tinnitus is phantom limb pain for your ears. I tried all the supplements that you're supposed to use for tinnitus for a year. Then I called my audiologist referral at Good Sam Audiology Lab that does my vestibular testing and asked her what tinnitus is. And she says it's phantom limb pain for the ears. So the best treatment for tinnitus is this hearing aid I wear. I wear my hearing aid and my brain gets the frequency information from my ear and it stops humming to itself and my tinnitus goes completely away until I go to bed and take my hearing aids off. Sorry, I can't put tissue back that's not there. Can you overuse it, have too much electricity in your body? Not usually. I had 11 machines on one patient on Monday because she was really complicated. I treat football players 5, 6, 7, 8 hours a day. No, not 8, probably about 6 hours. I treated Terrell Owens. When you read the book, you find out I treated Terrell Owens and fixed his legs so he could treat in the Super Bowl, play in the Super Bowl after 6 weeks after career-ending injury. Is there a preset program FSM home unit useful for migraines? The vagus nerve, vagal nerve stimulators are approved for the treatment of migraines. Our vagus nerve, vagal tone or vagus nerve program is so effective. It's patented actually by a corporation that's building a device I can't talk about. But yeah, so we use vagus program. Some migraines are not actually migraines, they're C2 nerve root, nerve pain. So you treat the C2 nerve root. Some migraines are not migraines, or the C2-3 facet that refers pain, feels like you got a poker in your eye. So there's different kinds of migraines. I could do a webinar on just migraines. So yeah, start with the vagus, treat the neck, treat the C2 nerve root, look at the diet, look at whether or not they can phosphorylate B6 if they're menstrual migraines, CoQ10 for those. Michelle, I'm an RN in California planning to go to the core in Phoenix. Oh, that is going to be so much fun. You haven't signed up yet. Sign up fast, girl. The class is filling up. I want to make sure this is something you can do as a practitioner within your scope of practice. Yes, there are other RNs. If you are a family nurse practitioner or an NP, you can do it without working in an MD's office. If you're in a state that allows you to see patients unsupervised by an MD, so you're not just assisting an MD, but you have an independent practice as part of your scope, that will vary by state. So I can't tell you what California's laws are, but you can check with your board and find out if you can treat independently. But there are other RNs, probably 20%, 20 to 30% of our practitioners are MDs. RNs are probably 10 to 15, 20%. Absolute contraindications and precautions. There's some theoretical ones based on the fact that they're TENS machines, so you're not supposed to use them when a patient has a pacemaker. We found out, practically speaking, that you can't run them from, you can run, as long as you don't run them through the chest, you're okay. I've done it by accident when I didn't know the patient had a pacemaker, got away with that. But we know for sure you can treat from the collarbone up and the belly button down. Not supposed to run TENS devices through the brain. And we do not run current through the brain in case the patient has an unsuspected seizure focus. And TENS devices are contraindicated. You can't run a TENS device through a pregnant uterus. You can't treat a pregnant patient, period, with FSM. Once you know a patient is pregnant, you can't treat them with FSM. Why is that? If you reduce inflammation, you know for sure you're going to reduce prostaglandins, LOX and COX. Use 40 hertz, and we do almost all the time. Use 40 hertz. The LOX and COX are going to go down. There are certain prostaglandins. We don't have a guarantee that LOX and COX are the only prostaglandins that are going to go down, and there are certain prostaglandins that are required to maintain a pregnancy. We don't, thank you. So we don't do that. Once a patient's known to be pregnant, you absolutely do not treat her with FSM. The other thing is that, you know, those endorphins that went up so high, it means the patient's relaxed, a little bit stoned, and they're fine. They're going to sleep fine. But the problem is, once the patient knows they're pregnant, 6 to 8 weeks is when they figure out they're pregnant. By that time, the fetus has a brain, and that brain is setting the firing threshold for endorphins and different neurotransmitters. You could see from those graphs that we are changing neurotransmitters pretty significantly, substance P and endorphins specifically. So the firing threshold for endorphins for the mother is very temporary, but it could affect the fetus's firing threshold for endorphins for the rest of its life, because that threshold is set during pregnancy. I have a hard and fast rule that once a woman is known to be pregnant, you don't get to treat her. I've been in pain for 12 years. That's okay. Another 8 months isn't going to kill you. And I'm not going to treat you. We just don't treat patients. How challenging is the use? It depends. If you're treating something simple like nerve pain, wound healing, diabetic neuropathies, all the basic easy stuff, shoulders, low back pain, the stuff we teach you to treat in the core, that's easy. We see some pretty crazy stuff. Patients with brain injuries, strokes, combination of brain, spinal cord, spasticity, increased tone from cord injuries, scar tissue in different nerves. Sometimes it's just dead easy. Sometimes it makes your brain hurt. If you like to think, you get to enjoy the more complicated patients. If you want to do just the simple cookbook stuff, you treat the easy ones and you send the complicated ones to somebody down the road, or they end up in my office in Troutdale. What did I mean by the learning curve? Learning curve is you start with conscious competence. You're good at what you do and you know that you're good at what you do, and it's just easy. You just do what you do. You're good at it. Then you learn something new. And then you are consciously incompetent at the new thing. Then you get better at it, and there's learning curve. It's pretty steep in the first 3 months. Then you are consciously competent. You're good at it, but you have to think. You can't just phone it in. You have to think. And then you become unconsciously competent again at the new thing. So that's the normal learning curve. With FSM, it's like you get good at necks and low backs and nerve pain and the shoulder, and that part's easy. And then it's like new patients arrive like on a bus, and you're going to see 6 things you've never seen before, and it makes your brain hurt. And you email me or you email the FSM group on Facebook or Blue Sky, and somebody will answer you. The whole team, we have 7,000 practitioners in 23 countries. So somebody will tell you, give you some advice on what to try. So the device's name, it's a microcurrent machine. We use the Precision Care. It is a not automated unit. You get to put in the frequencies as you go. So you're treating something and all of a sudden you feel around, and that is scar tissue in between the ovary and the sigmoid colon. Is that what I'm feeling? So you run the frequency for scarring in the ovary, scarring the sigmoid colon. The scar tissue dissolves and the patient's pain goes away. So I guess you were right. That's the Precision Care. You have to put in individual frequencies on channel A and channel B. I have some of the programmable unit is called the Custom Care because it is customizable. You have software for that one. And so there's a protocol for low back pain, neck pain, SIBO, asthma, I don't know, knee pain, delayed onset muscle soreness, flu respiratory, because you can't call anything COVID, common cold, sore throats, asthma. Those are just standard, unless it's something really special that you need to specialize by hand. Once you figure out what it is, you can program it into the custom care. And so that's an automated unit. Anonymous, thank you. FSM works. I'm a spinal injury recovery person who learned the hard way to know what to do. I can live my life now. Welcome to our club. This is what makes it all worthwhile, folks. Change one person's life. Just think of the world that changed because this person can live his life now. This is why we keep doing it. I'm a complete wuss when it comes to pain. How painful is it? Doesn't hurt. It's just really weird. You've got this nerve pain, sciatica, and then it just goes away. That's it. Now, when you're working on somebody's armpit and trying to increase the range of motion, you reduce inflammation in the nerve so it doesn't hurt as much. And then you treat scarring in the nerve and you increase the range. And when the armpit gets sore again, that nerve and muscle is connected to the patient's upper lip and they go like that. And then you just run inflammation in the nerve, it stops hurting. And then you can't feel the current. It's the same kind of current your body produces on its own. The current's not painful. And the practitioners are supposed to use their hands very gently. If they're hurting you, they're doing something wrong. Thank you for a great explanation of the impossible. You're very welcome. I'm glad it worked. I had really fun reworking those slides. Can LVNRNs use this with patients or can we become certified? I can certify you, but you have to check with your board to find out if you can use TENS devices independently as part of your scope of practice in the state that you practice in. There's just too many different states with too many scopes for too many different professions. We have probably 20 professions that use FSM. If we do this over video, as you're in Canada, do we travel for the practical part? I have instructors in most countries. You may have to travel for the practical part someplace. So you may have to go to Chicago. You may have to go see Alma. Where is she?
She's in Canada.
She's in Canada in that place in the middle with the horses. Starts with a C. It'll come to me. Do sound or other mechanical frequencies work as effective as FSM? The short version is no. Other frequency devices, the mechanical ones, like people that use tuning forks or musical sound, what do you call it? The monks with are relaxing and they can help somebody feel better. But I haven't found anything that works the way that FSM does. I may be prejudiced. There are some electrical devices like the Newbie and some of the other ones. But yeah, FSM is unique in its effectiveness. Calgary, that was the place. Thank you.
Thank you, Carolyn.
And the one in Canada. Frequencies for tinnitus. I can't put tissue back that's not there. You have high frequency hearing loss. Your brain is humming to itself. The best solution for tinnitus is a decent set of hearing aids. Oh, you're welcome for the inspiring introduction. How are the frequencies of conditions and tissues identified? I swear to God, I got them on the list. And it took me 5 years and 50,000 patient visits to prove to myself that the frequencies on the list were always correct. They always did, but they only did what they were described as doing on the list. And that's it. I was a hard case. Took me 5 years and 50,000 patients before I gave up and said, okay, they really do work. Baker's cysts on the knees. I keep waiting for lightning to strike when I say it's easy. You have to figure what's causing them. Baker's cysts are just the pouch of fluid created by inflammation in the knees. You have to strengthen the quadriceps. Use FSM as an adjunct to what you're already doing. So if you're a PT and you know how to treat Baker's cysts, you're going to do it with exercise and strengthening and using FSM instead of ultrasound or whatever else you're using, just because FSM works better. If you're an acupuncturist, you can stick needles in it and you can, because that's what you get paid for, right? That's what the patients expect, but you can treat the Baker's cysts and the inflammation in the knees with the FSM. So it's pretty straightforward. I know it sounds weird, but it's just not that hard. I'm glad you enjoy the books. Thank you very much. Is 40 the only frequency that's an issue if you're sick? All frequencies. There's a list. There are a couple of pretty irresponsible people that annoyed me a lot and scared the hell out of me a lot in about 2018. They listed all the frequencies, and there's some person that has created a book. That's just a whole list of every frequency that we use and anybody else uses. Thing is, they don't mention the contraindications. So you don't use 40 hertz if somebody has an infection, because the body uses inflammation, 40 hertz, to contain infection. You don't use the frequency to dissolve blood clots, because it actually dissolves blood clots. What if somebody has a deep vein thrombus? Okay, you're going to use the frequency to dissolve this deep vein thrombus, but is the blood clot going to come apart all at one time? Or could it form little chunks that are going to float up and give you a stroke or a heart attack? I've got a whole list. Do you ever want to increase secretions in the kidney or the sinuses or the lungs? The answer is no. Why would you do that? The kidney's endocrine organ. So there are some definite contraindications that I make you aware of during the course. And the people that publish those frequency lists did me a favor and did publish the contraindications, and we have them published on our website. You should show an image of the fourth phase of water. I love that book, and Jerry Pollack always speaks at our symposium. The fourth phase of water is in some ways better than cells and gels. But when you read Cells, Gels, and the Engines of Life, it completely changes your knowledge base about cell biology. It was a game changer for me. Cells, Gels was a game changer. The fourth phase of water is a completely different topic. And I agree, it's just an amazing thing. We do not treat cancer, number one. We just don't. We don't know enough. If I do something by accident and make your pain worse, it's just pain. It may affect your quality of life for 24 hours, but it's not going to kill you. If I do something by accident to make your cancer worse, there's a chance you may not have time to get back on top of it. And the other thing is, the best way to get any treatment shut down, especially in the United States and certain parts of Europe, is to advertise it, especially if you're successful, as treating cancer successfully. It's just, there's the medical ethical reason. I just don't know enough about, and there's so many different kinds of cancers. And the other thing is just the legal part of it. It's just too dangerous with the FDA to treat cancer. You can end up living in the Bahamas or Mexico, and I'd really rather stay in the United States. Oh, C5-6 quad. Oh, yikes. Spinal cord contusion without transection of the cord. Wheelchair bound since the injury, limited movement, no movement, lower extremity. Oh, 12 years ago. It's worth a try treating Vince. It's worth a try treating with FSM. 5-6 quad is, the cord wasn't transected, but the problem is, if it was just cord contusion, it's possible that the bleeding has produced bruising in the cord, and the swelling from the contusion can be enough so the cord doesn't transect, but the swelling can break axons in the cord, different pathways in the cord. The pain that she experiences, that's a possibility. Spasticity, that's easy. Restoring movement, I'd say there's a better chance with her upper body than it is with her lower body, but it's worth a try. You're an osteopath. Take the course. I'd buy a custom care if you're just going to treat your mom. You might need a precision care to figure out what to do. If you're going to use it in practice, you're going to want a precision care plus a custom care. So that's a thing. I have somebody treating me for chronic daily headaches Friday. Could she reach out to you with questions? I'm a tough case. Most headache patients, that is the supine cervical practicum. Oh, ick. That's a supine cervical practicum, and she just needs to get better at treating it. And yeah, she can reach out with questions. Go to contact@frequencyspecific.com. Back to Vince. Mom is on a maximal dosage of gabapentin for severe neuropathy. Yeah, that means that she's probably got thalamic pain. So when you transect the cord or part of the cord, or at least the pain pathways in the cord, you end up with what, if you interrupt the pain pathways in the spinal cord and the anterolateral pathways, you end up with thalamic pain. And that's easy to fix. I know that sounds bizarre. It's a crazy thing to say, but it's just 40 and 89. It's the frequency to quiet the activity of the thalamus. It usually lasts an hour or two the first time, and if you run it, it'll work every time you use it. And eventually it'll last 12 to 24 hours, sometimes 2 to 3 days, if you're lucky. And that part I know I can fix. That's 40 and 89. And then you can drop the dosage of gabapentin, which means your brain's gonna work a lot better by the time you're on 500 to 1,500 milligrams of gabapentin. You can't think too quickly. Teen patient, adipose inflammation around his larynx. That's what? There's a doc that worked with you at Cleveland Clinic. That'd be Dave Burke. Super concerned about testing any treatment on this anywhere other than into the hospital, as at times the inflammation can make breathing difficult for him. Some therapy bring down the inflammation. Of course, there's no cancer, no autoimmune. That's nuts. Inflammation in the number one, there's no adipose around the larynx. You gotta wonder, you treat his vagus nerve to reduce inflammation, make the larynx work better, and then you just treat the frequency for inflammation in the larynx. There's any experienced FSM practitioner should be able to treat this in their office. He's responded favorably to hardcore autoimmune arthritis medicine, which means it's inflammatory. Does he have an autoimmune disease that involves his larynx? This is the thinking about what caused it, where does it come from, how do you fix it, how do you approach it? There's more to the history than this. So adipose inflammation around his larynx, it sounds like some kind of asthma. If he was going to be treated in somebody's office, just make sure he brings his inhaler and his EpiPen. If something goes sideways, you've got medication to work with. And we're better at reducing inflammation than just about anybody. Got 2 of your books, very exciting. I'm glad you're having fun. Trying to sign up for the core in Phoenix in March. There's a box for a coupon code. Is there a coupon code someone could give to me, please?
I will send that with the information tomorrow.
Okay, Kevin's gonna, everybody that signed up for this, Kevin's gonna send out the code tomorrow. You can email contact@frequencyspecific.com. What's the best way to figure out placement for towels and leads? There's pictures on every slide in the core, and then you get to practice. If you want information about the devices, go to www.precisiondistributing.com, and that's the devices. Once you've taken the core, you'll be able to see the prices. We don't advertise the prices to the patients, because if you want to sell devices to the patients and you want to mark them up, we don't want the patients to know how much you mark them up. Abby from Portland. We do not treat obstructive sleep apnea because sleep apnea is a fatal condition. I do not treat fatal conditions. If you have obstructive sleep apnea, get a CPAP. And then you can talk about anything else you want. As long as you are treating the sleep apnea with a CPAP, then I'm happy. But no, you can't. I haven't found anything. Sleep apnea is just too dangerous. There's a book called The Promise of Sleep, and it doesn't matter what else you have. If you have sleep apnea, that is what is going to kill you. Period. End of discussion. There are no exceptions. Okay. So that's one of my hot buttons. Sorry. ADHD. Yes. Dave Burke has done some great presentations on that. Jessica, should we read your Elsevier book prior to taking the core? I'd really rather you read The Resonance Effect, and then you can, then I'd watch the core on video first. You can read the Elsevier book. It's more the science behind it. Elsevier makes you references for everything. So it's more the published literature that's on the conditions retreat. Ringing in the ear, can't put tissue back that's not there. The solution for tinnitus is good hearing aids. Can you clarify? You suggest watching the videos before going to class? Yep. Are these included in the price? Yes. So when you sign up for the course, they will send you a link to the videos and you can watch the videos. And that way you can pace yourself. It's like taking a drink of water out of the fire hose. I would love to be one of those people that makes you take 6 courses. But what if you only take 1 or 2 courses? What am I going to send you home without? So I'm going to torture you, teach you for 5 days. And at the end of 5 days, you decide what's important for you to know about, right? So there's a physical medicine section, there's treating neuropathic pain, there's treating the central nervous system, there's treating PTSD, there's treating fibromyalgia. It's supposed to be a whole day on visceral conditions, and usually we end up doing that for just in an afternoon. Geographic tongue is caused by B12 deficiency. What the patient needs is methylated B12 or hydroxylate adenosine hydroxy B12. That's what causes geographic tongue. Methylfolate, methyl B12, and even then it's 6 to 8 to 12 weeks. FSM cannot cure B12 deficiency. For SIBO, does the treatment require several times? Oh, yeah. And you've got to be doing all the other stuff besides for SIBO, but you don't have a single cell in your small bowel that was there a week ago. So why do people think it's normal for SIBO to last for 10 years? It drives me crazy. With FSM, you get the vagus working, you treat the gut to reduce inflammation, and you treat leaky gut, and then you treat the candida and the bacteria, and you get the vagus working so the sphincters work, so the stomach acid works. And it takes maybe 12 weeks for SIBO, assuming you have taken care of the antibiotics and you're taking Saccharomyces and you're taking friendly bacteria and you're taking huperzine A to support the vagus. And it's about twice a week for 6 weeks. But that sure beats what seems to be normal, which is 4 to 10 years. No, you can't. Are we able to purchase custom care before taking your course? I'm afraid not. I'm really sorry. Because you don't know what you're doing. It's like handing a 3-year-old an Uzi, right? You take the course. Once you take the course, you'll be entered into both the PDI and the FSM system. And once you've signed up for the course, you can buy a custom care. But you got to know what you're doing. Why does FSM flip the frequency polarity every 2.5 seconds? It's just because that's how the microcurrent devices work. The frequencies pulse every 2.5 seconds. I don't know if the Abrams devices ever did that. I've never seen one of the Abrams devices. I've never used one. I have no idea where those frequencies came from. I have no idea how they're worked. All I know is I've been using microcurrent since 30 years, since 1994, 95. And the frequencies pulse every 2.5 seconds. It's a good question, Alex. You ever figure it out? Let me know. Neil Nathan and Roger Billick both recommend FSM as an adjunct to Lyme's, and it helps reduce the inflammation. There's a frequency for spirochetes that seems to help, and Lyme's complicated. I'm sorry, but it just is. So it takes antibiotics, it takes time, but part of the challenge with Lyme is that it turns off the vagus. So we turn the vagus back on. Now the infection, if it's still around, is going to turn the vagus back off. But I can give you about 2 to 3 hours of relief where your vagus nerve works. And then we can reduce inflammation in the brain and the spinal cord and wherever the Lyme has landed. It's pretty amazing. Molly, other stroke experience, which frequency is sensory motor? Sensory motor cortex is 92. And ultimately, what we do is increase the secretions in the sensory motor cortex and reduce the inflammation. And I've treated thalamic strokes are actually the easiest, believe it or not, because they create body pain. And all we do is quiet the inflammation in the sensory motor cortex and the pain goes away. I've treated cerebellar strokes. They're a little tricky. Strokes in the medulla usually kill you, which is actually good news. And medulla strokes are tricky because all of the pathways cross and you're treating every pathway in the spinal cord where it crosses in the medulla, plus the vagus, plus everything. Right now, I'm treating a patient that had a bleed at the base of her brain that affected everything, every cranial nerve. And we just found a list of all the cranial nerves, and I'm just finding out that those worked. Now, in 30 years of doing this, I've never treated cranial nerves. There we go. I'm talk about your learning curve. I'm still learning things 30 years later. So do we answer all the questions?
There's one more.
I just can't get down to it. Can you fix it?
Bar there and slide it.
It won't.
Oh,
It won't move.
okay.
Can you
This
tell me
says-
what the question
yeah,
is?
it just says, how about the impossible?
How about the impossible?
And I can't.
How
can't-
about, oh, androgenic alopecia, male pattern baldness. I am so sorry. We had one practitioner that did a case report on it, and he's been successful, but male pattern baldness is genetic. If your dad was bald, you're going to be bald. And it's just, it doesn't matter whether you're male or female. I'm really sorry. I've just never had any success with it. I had one practitioner that said he had success. There's a frequency for hair roots, but in male pattern baldness, there's a point at which the hair roots just die. I can't put tissue back that's not there. It makes me very sad when there's stuff I can't do. And there's another question just below
One
that.
last question basically just says, if I attend the core course in person, will I receive the slides and material for review at a later time? Yeah, you receive all of that before the course. So you'll have all of that to review before you ever even get there.
When the person that's asking about if I purchase a core, do I get the slides? I'm here to tell you, you get the core slides. There's 1,040 there. I'm going to add 2 of them. So there's going to be 1,048 slides to the core. Then there's a core practicum, which is different. It tells you how to do what, and it's just stepped up by step: supine cervical, supine shoulder, low back, and then joints, and then nerves, central nervous system, whatever. You get the practicum slides, then you get the summary slides, and then there's an equipment practicum that shows you how to set the machines up. So you end up with 4 booklets. It's a lot. And it's all I can tell you is it's worth it, because it's just the most fun you can have in medicine. It just is. Thank you all for coming. I had such a great time. I hope you did too. And I'll look forward to seeing you at a seminar at some
Look for
later.
my email tomorrow.
Say again?
Look for my email tomorrow.
Oh, and look for Kevin's email tomorrow. Make sure to check your junk folder. It's going to be there because he will do that. From Vince, you're welcome and good luck with your mom. That's so hard. It's great to see you too, Molly. And I just thank you all for being here. Do good things, save lives, take care of yourself, stay joyful. Bye.